So we'll proceed with the first talk of this session. It is Hypothalamic Pituitary Axis Suppression, Troubleshooting the Complications. And for this, we have with us Professor Khurshid Ahmad, who requires no introduction. So please, sir, if you could take on the stage.
I'm very thankful to Pakistan Endocrine Society and chair of scientific committee to invite me for this on this prestigious forum to come and give a talk on hypothalamic pituitary axis suppression, troubleshooting the problems there. Let's start with this patient. This is a 40-year-old male resident of a village around Sahiwal. He presented with complaints of about 15 kilo weight gain and body aches over the last 1 to 2 years to a general practitioner in his city in Sahiwal. 3 months ago, he was diagnosed with prediabetes and hypertension. Blood pressure when he went to see his GP was 140/90. Body mass index was 35. On physical exam, he had round faces, buffalo hump, and abdominal striations. Anji, anyone from the audience, can you tell me what does it look like? Cushing lagta hai. It looks very straightforward thing. So obviously, this was his picture from a few years back, and this is his recent picture. It gives you typical the Cushingoid look. He looked Cushing, and so his general practitioner, what he did was, he did his TSH, free T4, few other tests. I just made it very simple here. ACTH was done, which was 2.04. Cortisol AM was 3.6. So what do you think what's going on with the patient? Anyone from audience? Iatrogenic. Iatrogenic, that always is a concern in anyone who comes in with a Cushingite feature, and this has suppressed. If you go back on the history on this patient, he had this body aches over the last 1 to 2 years, and he was, but anyhow, his general practitioner, when he saw these labs, he referred him to an endocrinologist to be evaluated to see what is going on with him. Not knowing that he was using steroids. On further history, on further questioning, it did find out that he had been, because of the chronic back pain, he was seeing some kind of dispenser in his village who would give him different medicines, including injectables. He did not know what those injectables were, but we all know that most of the times these steroids, they make patients feel good, they make the pain go away, and they just stay hooked on those drugs. They keep going back to the same person who's treating them, because their goal ultimately is to get rid of the pain and the symptoms. But that's causing long-term problems on this patient. So obviously we all know this is an iatrogenic Cushing in this patient. And that has caused hypothalamic pituitary axis suppression in here, as evident by the ACTH and cortisol levels which were done on this patient. So where do we go from here? What should we do for this patient? Anyone from the audience, especially our fellows back there, can you guys tell me what should we do further on this patient? Start him on hydrocortisone. Do you want to do any testing before you want to put him on hydrocortisone? Because that always is a question there, what should we do? Because yes, he has an iatrogenic Cushing, and are we going to just put that label and make him adrenal axis? I see a lot of my senior professors sitting in the front seat, they are shaking their head, no, I would like to do something else here also. So let's go through a few slides, and then I guess we will discuss this again. We'll come back to this patient after a few more slides. So hypothalamus axis can be considered the coordinating center for endocrine system. Hypothalamic pituitary axis directly affects the function of thyroid, adrenal, gonads, as well as influences the growth of the person, milk production, and water balance. So it's a very vital organ present within the system there. And when it comes to the regulation, we know especially hypothalamic pituitary adrenal axis, hypothalamus CRH is produced, ACTH is produced with effect from there, and then adrenals, they produce the cortisol, and then there's a negative feedback at pituitary, and then negative feedback at hypothalamus. Yes, there's some impact of vasopressin and pro-inflammatory cytokines at pituitary levels, and there's some impact of different stressors in the form of hypoglycemia, hypotension, surgery, fever, injury at the hypothalamus level as well. So this is very basic physiology slides. Let me give you a couple of more physio slides just to refresh our memory together on this. Adrenal gland, we know this is 20% of the adrenal gland is adrenal medulla, rest is the adrenal cortex. In adrenal cortex, the glomerulosa is 15% of the weight of the adrenal gland, fasciculata is about 78%, and radicularis is 7%. All three different zones produce different hormones. Glomerulosa, aldosterone, this is for our fellows, just to go through that and revise their physiology. Zone of fasciculata produces cortisol, corticosteroid, cortisone, radicularis, dehydroepi, androsterone, and adrenal medulla, we all know, produces catecholamines. And renin-aldosterone system, the RAS axis, again, a slide from physiology, the liver angiotensinogen is produced, kidney in response to many factors, renal perfusion, juxtaglomerular apparatus perceiving how the blood flow, blood pressure in there is renin, that converts this into angiotensin 1, and in lungs, and ACE enzyme, it converts that in angiotensin and angiotensin 2, which ultimately leads to production of aldosterone from the adrenal gland. Volume status, hyperkalemia, the main stimulants for the aldosterone production, even though I would say there's some impact of ACTH also, about 5 to 10% in production of aldosterone there from ACTH as well. Just a couple of slides real quick, and then I'm going to come back to the clinical part. Major causes of hypopituitarism, hypothalamic diseases, mass lesions, radiation, infiltrative lesions, infections, traumatic brain injuries, pituitary surgery, radiation, infections, apoplexy, genetic mutations, empty cella infection, and abscesses at stroke can cause that. Drugs is one of the very important and most common cause what we see in our patients, especially, like I say, there is not uniform health care within our country. There are patients who are seeing people who are just have done matriculation and they are running the clinic. The other day I just saw this was very interesting. This lady, about 70-year-old female came to me with uncontrolled diabetes by her son, and then I was giving her some advice. I was explaining the son, and this lady, she says, "Doctor Sahab, mera beta bhi apne gaon mein bahut bada doctor hai." And he was like, "Nee sir, maine to bas matric karke bas kaam shuru kiya hua." He was very he felt kind of embarrassed when she introduced, but to mother it was a good doctor. So, but reality is in our rural area, we still are very short in healthcare providers, proper healthcare providers, doctors. In a lot of rural areas, this is how the practice is done. When I was posted as medical officer in basic health unit after my graduation from KE, King Edward Medical College. The basic health unit I went, that was in Renala Khurd next to Ukada. In there, the peon, the जो चपरासी होता है ना उस basic health unit में, वो शाम को clinic किया करता था, क्योंकि डॉक्टर तो कभी उस basic health unit में आता नहीं था, तो मैं आया तो उसने खैर अपना clinic move कर लिया. साल में रहा, वो काफ़ी मुश्किल में उस दौरान रहा. फिर साल बाद I moved, went to US, so that's where when, so in our rural areas we see a lot of this abuse, how these medications, they are used inadvertently without any indications and in excessive doses and excessive amounts there. And then of course their adrenal causes could be autoimmune, infective, and others as well. So, coming back to our clinical stuff, this was just a review, just taking walk down the physiology path. How do we diagnose adrenal insufficiency of our patients? And then we will come to our patient after that. Checking an 8 a.m. fasting cortisol level can usually make or exclude the diagnosis in a patient level of cortisol less than 5 or more than 12. If you did an AM cortisol and level is less than 5, of course this patient is adrenal insufficient, level is more than 12, well, patient is more than likely is okay from adrenal standpoint. should only be done in, so not everyone should be tested to adrenal testing, but should only be done with signs, symptoms of adrenal insufficiency or history consistent with that. This is not your routine test, but test based on specific indication. Can be used in patients with moderate, even a mild index of suspicion for adrenal disease, primary or secondary. Measurements of ACTH can differentiate between primary and secondary in these patients. Consistently high ACTH in a patient with a normal cortisol level could be an early sign of adrenal insufficiency in that patient. The criterion for serum cortisol on ACTH stimulation, the second test is ACTH stimulation has to be done on certain patients, and remember, someone with a cortisol level between 5 and 12, these are borderline patients. They could be partially adrenal insufficient or more severe. So in those patients, ACTH stimulation test is needed. The concentration of about 18 to 20 microgram per deciliter in these patients, either at a basal level or after IV injection of ACTH, is indicative of good adrenal reserve. A lower cutoff can be used in those patients, which is 16 microgram per deciliter if ACTH is administered intramuscular rather than IV. Another pitfall sometimes is incremental or percent increase in cortisol should not be used to assess the response to ACTH, because individuals who have a high basal serum cortisol concentration due either to a normal circadian rhythm or acute stress may be nearly maximally stimulated and unable to increase cortisol secretions in further. So what really needs to be done is what is the highest level we achieve in these patients, either in a basal state or after ACTH stimulation. Now, when steroids are the culprits, hypothalamic pituitary adrenal axis suppression, steroids being the culprit, it's important to identify patients with HPA suppression, because not all patients with HPA axis suppression should be dealt the same way. There is a difference depending on what is the likelihood of HPA axis suppression and what is the unlikely situation. So the potency, dose, and duration of glucocorticoids are important, but imperfect indicator of presence of HPA suppression. There are other features, a clinical decision about particular patient's risk of having HPA suppression guides subsequent decision making other glucocorticoid tapering should be done or not, and how it should be done. So important to classify these patients who are on glucocorticoids and then manage accordingly, and I'm going to show you next two slides how do you tell where HPA axis suppression is unlikely and where HPA axis suppression is likely. Patients who meet one of the following criteria regarding glucocorticoid use are less likely to have a suppressed HPA axis and therefore may have glucocorticoids can be weaned as appropriate for the underlying disease. These are the patients who have received glucocorticoids for less than 3 weeks. There's an unlikely chance that their HPA axis will be suppressed if for the primary disease for which the steroids were started, that disease permits you to wean these patients off steroids. By all means, they should be gradually weaned off steroids and see how they do. Patient treated with alternate day prednisone at a dose of less than 10 milligram or its equivalent, even for the long term, these patients usually with this dose and with this gaping in the interval usually do not go into HPA axis suppression. So these are the patients where the suppression is unlikely. So instead of subjecting them to extensive testing to find out how the adrenals are doing, we can decrease the dose and see how these patients, we can taper the dose and see how these patients are doing clinically, how is their blood pressure, how their GI symptoms are after we are trying to taper off, how their physical energy and their activity level is after all those. So that is important. So if withdrawal from glucocorticoid is otherwise indicated, gradual reduction in dose is appropriate in such kind of patients with a low risk. Such patients do not need to be tested for HPA functional reserve unless abrupt discontinuation. Yeah, sometimes there's a patient who's taking steroids and patient needs to come off steroids, but patient needs to go for surgery also for one reason or another. That's a patient I will not subject to surgery without testing the adrenal reserve in this patient. So when abrupt discontinuation is being considered, or the patient is facing an acute stress such as surgery or something like this, I will definitely check the adrenal ACTH, pituitary and adrenal status on this patient before giving go ahead for any of these procedures. Even in these patients where I feel it's a bit unlikely, but it's a safer practice, I would suggest. Now, in situations, what are the situations where HPA axis suppression is likely? HPA axis suppression may occur regardless of whether glucocorticoids are administered in the morning or evening, doesn't matter, while it may be reasonable to assume that any patient who has Cushingoid appearance, remember, our patient had Cushingoid appearance, has HPA suppression, but cautious tapering should be attempted and if needed should get tested as well for adrenal insufficiency. So here there is a bit of gray zone here. Should we directly go in these patients? Because if patient already has Cushingoid appearance there, the chances are HPA axis suppression is there. And here you need to see if we can do the taper and how this patient does with the tapering of steroids, or should we just go ahead and do this pituitary adrenal, the reserves, check their reserves, do the ACTH stimulation test on this patient or not. So a few more slides and we'll go back there. So patients, just to summarize what I said so far, patients determined to have a low risk for clinical significant HPA suppression may have glucocorticoids weaned as dictated by the control of disease. So that's kind of straightforward. Patients suspected of HPA suppression or otherwise candidates for glucocorticoids withdrawal can be cautiously tapered, but certainly if we feel like they are getting into because feel like their blood pressure is dropping, feel like they are not doing well, we definitely need to do the dynamic testing and see and go from there. Patients for whom the likelihood of HPA suppression is uncertain. Then, like our patient fell in this middle range, but then there are patients who are taking steroids for the long term. You're not sure, and they're not Cushingoid either, but they've been on this for a while, for the long time. And patient tells you at times that when the day I don't take it, I don't feel well on that particular day. So when the HPA axis suppression is uncertain, but for whom the consequence of developing acute adrenal insufficiency are serious, those are the patients, for example, they want to go for surgery, they may benefit from testing of HPA functional reserve to guide further therapy. To make things very simple for my all the fellows and other students here, I would say someone where the patient fulfills the criteria where HPA axis suppression is unlikely, that's a straightforward thing. You can gradually taper it off and follow the patient. Where you feel like if in doubt patient does have HPA suppression or there's a possibility of suppression, I think it's a safer practice to test these patients for pituitary and adrenal reserve before we let go these patients off steroids completely. And sometimes what happens is a patient is taking a low dose of 5 milligram prednisone, like earlier I said, in a patient with a low axis. But when you try to take that patient off these medications, patients start to show symptoms related to adrenal insufficiency. So nothing is like a blank check for you that for any given level, you just on one certain day, patient comes to you and you tell the patient, okay, you stop this, go back, and you are good to go. You need to follow up these patients. You need to tell the patient, give the patient some symptoms, what are the warning signs and symptoms which patient should be looking for, and call you. Usually what I do, I give these patients my personal number and tell them to call me or WhatsApp me, and if I cannot reach back to them soon enough, they should go to the nearest emergency room for evaluation so that we don't lose any patient because of adrenal crisis or so. So case 1, this was a patient I mentioned earlier, where we go from here. We can debate on this, what should be done on this patient, but this was a patient who was taking different medications, injectable tablets for past 1 to 2 years for chronic body pains, I will definitely do an ACTH stimulation test on this patient and see how it is. The chances are, my own feel is this patient ACTH stimulation test is going to fail, and then he would be needing a low dose steroids. And exactly this is what happened in this patient, where this patient was on chronic long-term suppression. So ACTH suppression the stimulation test did not yield any good levels of cortisol. ACTH was still suppressed, so patient ended up being on a low dose of steroid, on a maintenance dose of steroid, with advice to increase it in cases of stress or so. This is one patient I will bring back at some later stage and will reevaluate again. I mean, fine, I put a label for now on this patient. Yes, you have adrenal insufficiency, but I would like to bring this as a young patient, otherwise healthy. So I would like to bring this patient back maybe in 6 months' time and reevaluate his HPXs again at that point. Once he's on a much lower dose, I will try to keep him the lowest possible dose of prednisolone or even hydrocortisone, whichever is available around there. Another patient. These are real-time patients who I seen just in the recent past. This is a 26-year-old female who presented with concern about Cushing syndrome. She came to me clinic and she said, "Well, doc, I think I possibly have Cushing syndrome." I said, "What makes you say so?" She said, "Well, I have gained about 4 to 6 kg of weight in last 1 year, despite being careful with the diet." And she said, "When I look in the mirror, my face looks a little bit roundish." I looked at the face. I'm not sure. Some people have shape of the face is like this. I didn't feel there was a typical moon-like face or buffalo hump on this patient. And she said, "Well, I have a few stretch marks." She was married. I believe she had 1 or 2 children as well. Her BMI was 28. And she said, "Well, I Googled the causes for round face and found out that Cushing is one of the cause, and I want to be tested." So what would you do in a case like this? This is a question to my colleagues here. For a patient like this, what do you say, "Okay, yes, I should go ahead and test you based on this data"? You should say, "Well, let's see another few months and then come back and go from there." जी anyone कोई अगर मुझे input देना चाहे? You will test her.
Test.
Oops. Yep. जी?
Should take the detailed history first.
Detailed history first.
Detail
Yeah.
first, and do the examination.
Examination.
And
Okay.
look the types of stria she has.
Okay.
And then
And then, of course, the detailed history physical examination is very important thing. And she saw a physician like just before she came to see me, who's just examined her, did a very detailed history, and she said, "Well, your stretch marks are just like a regular patient with someone who had those pregnancy stretch marks, not really those purplish, wild, more than 5 millimeter wider striae there on abdomen, and you seem okay. There's not much weight. BMI is on 28, don't see any other issues." So she was reassured. She was sent home, and then a few months later she came to me, and I did the same thing what Dr. Umar said, because my thing is, if patient is worried about something and there's a slight possibility this could be there, better do it. So ended up doing this on this patient and tested. Patient came back positive with the ACTH independent Cushing syndrome. MRI of adrenal gland was done. 1.8 centimeter right adrenal adenoma was done. Bingo, we got our diagnosis. Patient was happy with me. Okay, someone listened to me. I was saying this for past many months, and no one was paying attention. So patient ended up going through laparoscopic unilateral adrenalectomy and was sent home by surgeon in about 3 days. After 3 days after surgery. So 48 hours after discharge, she presented in emergency with severe vomiting, dehydration with low blood pressure. Gee, fellows, what do you think what happened here? Gee? She developed adrenal insufficiency. So where was the mistake? Maybe here the coordination was not done with the, or maybe the physician or the endocrinologist was not on board. So patient was sent home without any steroid. So this is what ended up with this patient. So the question is, what do you do? We know what is wrong here. So what do you do in this patient? So we believe what happens in these patients is with the adrenal insufficiency, with the Cushing syndrome, once you take the unilateral, there's a possibility that this patient has tertiary adrenal insufficiency and is in adrenal crisis. That's it. And how would you diagnose that this patient has tertiary adrenal insufficiency or adrenal crisis? इमरजेंसी में वो आई कोई टेस्ट वगैरह करेंगे उसके कि नहीं करेंगे? देखिए मैं आप अचानक अपनी मैं बात कर, आई वुड लाइक टू इमरजेंसी में आई वुड लाइक टू से जो भी मेडिकल ऑफिसर से देखे कि इनका ACTH और cortisol at least आप draw कर ले before giving steroid. We all know that she needs to be steroid. So I will definitely check the cortisol and ACTH level on this patient before doing that. And the next question is, for how long this patient should be given steroid? She has one healthy adrenal. Yes, I understand her. She is in tertiary insufficiency, adrenal insufficiency at this point. So for how long it should be given steroids? So this is another patient we need to evaluate on a frequent basis to about 2 to 3 months, see how she's doing, how we can decrease the dose and reevaluate the status there, and how do we evaluate there. So I'm going to quickly go through a few more slides. So secondary and tertiary additions, we all know, I'm not going to waste time here. When hypothalamus gets suppressed because of excessive steroids, that's tertiary insufficiency there. So tertiary adrenal insufficiency we see with chronic high-dose glucocorticoid therapies or after the cure of Cushing syndrome. So let's save some time here. Another scenario which I want to bring it to you is, I'm sure Colonel Shah Saab is going to talk about adrenal adenoma, pituitary adenomas. Well, just one slide. In patients who have hypothalamic pituitary adrenal axis derangement post-surgery, in these patients, what my routine in these patients is again, this is an HPA axis suppression there. Early morning serum cortisol 24 hours after the previous dose of hydrocortisone was held. So, raat ko se hydrocortisone na de even in the early post-op period. Morning mein check kar le, cortisol acha aata hai, patient can go home without steroids. Acha nahi aata, then obviously the patient has adrenal insufficiency and then less than 5. But if the level is between 5 and 15 on a couple of times you do this, then those are the patients where we need to do further testing on those patients. So usually I would tell you that if I was talking about earlier within 48 hours to 72 hours after surgery. After surgery, if these patients during those times in hospital, the readings are in between this, you put those patients on steroid, send the patient home. And ACTH stimulation test should not be done immediately post-op because at that time, adrenal gland is not suppressed well enough, at least for first few weeks after surgery. So in those patients, it's good practice to bring them back after 4 to 6 weeks and do the ACTH stimulation test. If someone, for some reason, you want to do very early on testing, insulin tolerance tests or meteropon tests can be done, but they are cumbersome and usually not advised. Just few special consideration and then I will finish my presentation. Minor illness such as upper respiratory infection, the patient can increase the dose of glucocorticoids 2 to 3 times the usual daily dose for 3 days without consulting the physician, known the rule of 3. Increase the dose 3 times for 3 days for mild to moderate illness in these patients. Major things like surgery, for minor surgeries, a patient can have 25 to about 50 milligram of hydrocortisone on the day of procedure, have the minor surgery done, can go home and can go back to regular dose. Moderate surgery, hydrocortisone 50 to 100 milligram on the day of surgery and post-op day 1 and then can go home on regular days. Major surgery, that's where we need much higher dose, 100 to 150 milligram in 2 or 3 dividers on the day of surgery, post-op day 1 and post-op day 2 and then gradually bring it down to the lower dose in these patients. General anesthesia, IV sedation, these are the red flags, should not be performed in office setting in patients with HPA axis suppression there. during the month of fasting, what do we do on these patients? Patients on hydrocortisone should be transitioned to a single dose of prednisone administered at sari time. Essential that patient receive instruction on hydration, sick day rules when to urgently terminate their fast. So they need to be educated about when to terminate the fast, what to do during the fast, how to keep the hydration well, and bring the dosing maximum to the morning time. And when in bad situation, what is the situation when they should be giving either auto-injecting glucocorticoids, which are available in certain countries, or go to the emergency rooms. Pregnancy, that's another scenario there. I think this is the second last slide, and we'll finish very soon. The usual glucocorticoid and mineralocorticoid replacement doses are continued, and occasional women require slightly more glucocorticoids in the third trimester during birth. During labor, adequate hydration and 25 milligram hydrocortisone should be administered intravenously every 6 hours in these patients when they are in labor. At the time of delivery, if the labor is prolonged, hydrocortisone should be administered IV in a dose of 100 milligram every 6 hours or as continuously if you can. After delivery, the dose, of course, can be tapered and brought back to the maintenance level in 3 days' time. And occasional women with severe nausea, vomiting, and first trimester vomiting may require intramuscular dexamethasone at a slightly higher dose, 1 milligram per day. So, patients where we diagnose them with a secondary hypothyroidism, that's very important thing also. They may have HPA axis suppression also. Do not start them on steroid unless you check their hypothalamic pituitary adrenal axis. So steroids need to be given first before you give them thyroid hormones. Patients with hypopituitarism who have partial or total ACTH deficiency and receiving suboptimal dose are risk for developing symptoms of cortisol deficiency when these patients' growth hormone is initiated. So this slide I put in for our pediatric population. You want to start the growth hormone, adrenal insufficiency is borderline already in this patient. Address that, please, before you start this thing on these patients. Education is very important. What to do in major stress is very important. The patient should have bracelet. If the patient goes in coma, unconsciousness, the healthcare providers should know what is going on with the patient. And the most important thing, tell patient if does not feel good, things are not looking right, seek medical attention immediately. And with this, I will thank you all very much.